Good morning. My name is Hallie Prescott, and I'm going to be presenting on when to give antibiotics in COVID. I have listed my disclosures here. This work is funded by Blue Cross Blue Shield of Michigan. I've also listed other funding and relevant roles. And then I'm obliged to tell you that this talk represents my views, but not views of U.S. government, Department of Veteran Affairs, or any other organizations that I'm affiliated with. So I'll start with a little bit of background. I practice clinically in the state of Michigan at two different hospitals, the Ann Arbor VA Hospital, which is a smaller hospital with about 100 beds, and then the University of Michigan, which is a large tertiary academic medical center with about 1,000 beds. And both of these hospitals are located in southeastern Michigan outside of the Detroit area, which was really one of the parts of the US that was first hit hard by the COVID pandemic. We had our first case of COVID in Michigan on March 10th, and by March 31st, we were having about 1,500 cases per day. And Michigan was the third state in the US in terms of COVID-19 deaths, behind only New York and New Jersey. And I am the physician lead for a sepsis quality improvement program that was actually just getting started in January of 2020. And that work got paused as a result of the pandemic. But there was some irony to the fact that, we were pausing our sepsis quality improvement work while people were dying of viral sepsis from COVID. And so we were able to quickly retool our program to launch a registry to collect data regarding coronavirus hospitalizations across the state of Michigan. And in total, we had about 40 hospitals participating, and we had trained sort of professional chart abstractors from each of those hospitals. Michigan has about 20 different statewide quality improvement consortiums that predominantly focus on surgical care. And much of our surgical operations were paused during the onset of the pandemic. And so we were fortunate to be able to have those trained abstractors instead participate and support the data collection for this My COVID-19 registry. So again, we had chart abstraction by professional abstractors, and these were very detailed data collections. So the abstractors were spending about 2 to 4 hours per patient, depending on the length of stay. Historically, our sort of larger quality improvement collaborative on hospitalized medical patients has focused a lot on antimicrobial stewardship. So for example, recent work has focused on excess duration of antibiotic treatment for patients with community-acquired pneumonia, on excess treatment of asymptomatic bacteriuria, and also excess duration of fluoroquinolones after hospital discharge. And so when we first started looking into the data that we were collecting on our COVID-19 hospitalizations, one of our first questions was how often were patients getting empiric antibacterial therapy for potential community-acquired bacterial co-infection, since this was harmonizing with sort of our prior work on antimicrobial stewardship. And we found that among the first 1,700 hospitalizations in our registry, that 56.6% of them received empiric antibacterial therapy within 2 days of arrival. For this analysis, we excluded azithromycin since there was a fairly high rate of use of azithromycin specifically for COVID-19, and we were really interested in empiric antibacterial coverage for bacterial co-infection outside of COVID-19 disease. So again, we found that 57% of patients in our registry were treated with empiric antibiotics. When we looked across the individual hospitals in our registry, however, we found that there was marked variation in the rate of empiric antibacterial coverage. So you can see here in this figure, this shows the proportion of patients treated across hospitals that had at least 25 cases in the registry. And you can see that the rate varies fairly substantially. At the lowest end, hospitals were treating about 25% of their patients, whereas other hospitals were treating about 85%. So about a threefold variation in the rate of empiric antibacterial coverage. And whenever we see such wide variation in practice, it suggests likely an opportunity for performance improvement. When we looked a little bit deeper about what were the specific types of antibiotics that patients were receiving, we show here in blue the proportion that were getting treatment for community-acquired pneumonia only. So essentially antibiotics recommended for pneumonia based on American Thoracic Society or IDSA society guidelines. In black, we show the proportion that were receiving additional coverage for MRSA or Pseudomonas. And then in red, we show the very small proportion of patients that were getting other antibiotics not targeted at community-acquired pneumonia, MRSA, or Pseudomonas. So just as there was variation in the proportion of patients getting antibiotics, there was also variation in the types of antibiotics that hospitals were prescribing. When we looked at the factors associated with empiric antibiotic use, I think things that you would probably predict are what fell out. So older age was associated with greater antibiotic use or more likely to get antibiotics. Patients who were requiring substantial respiratory support upon arrival to hospital were more likely to get antibiotics. People with chest imaging suggesting a focal or lobar infiltrate, people with elevated white blood cell count on arrival to hospital. And then we found a fairly substantial difference over time. So in March, when we were getting our first cases, there was a much higher rate of empiric antibiotic use occurring in 67% of all hospitalizations in our registry. This declined to 47% by April and remained stable through May. We also found that there was differences in empiric antibiotic use based on the type of hospital, with a higher proportion of patients being prescribed antibiotics among those treated at for-profit hospitals. Importantly, we found that community onset bacterial co-infection was quite rare. So again, among these 1,700 patients in the registry to date at this time, only 71 had evidence of a community onset bacterial co-infection based on either culture data or additional non-culture based testing. So that was only 4% of our cohort. So in this table here, you can see that 64% received blood and or respiratory cultures, and then 55% received additional testing, either a respiratory PCR test, Legionella, or streptococcal antigens. And again, across all these different types of testing, only 4% of patients were found to have confirmed bacterial co-infection, which was largely diagnosed based on culture as opposed to the non-culture based testing. We found that the COVID-19 testing, and specifically the turnaround time, was key. So among those patients who were started on empiric antibiotics, 57% of them had their antibacterials stopped within 1 day of their SARS-CoV-2 test result. But even among those who had their antibiotics continued even after they were confirmed to be COVID positive, only 6% of those patients turned out to have a confirmed community onset bacterial infection. So we see a big discrepancy in terms of the rate of empiric antibiotic prescribing and the actual rate of bacterial co-infection among patients hospitalized with COVID-19. Just recently, there was a pre-publication. This is a systematic review and meta-analysis looking specifically at bacterial co-infection, both at hospital admission and then also secondary infection over the course of hospitalization among people with COVID-19 disease. And here is the visual abstract from this study. The authors identified 28 studies for inclusion, which totaled about 3,500 patients who were hospitalized with COVID-19 during December 2019 through March of 2020. And very similar to the findings in our registry, they found a 3.5% of the patients had confirmed bacterial co-infection on presentation to the hospital. An additional 15% were subsequently diagnosed with secondary bacterial infection at some point during hospitalization. And again, very similar to our registry, they found a high rate of empiric antibiotic prescribing occurring in 71% of patients across this pooled analysis. This here is a figure that sort of talks about how do we decide whether to prescribe antibiotics. So on the one hand, we know that we want to give antibiotics as soon as possible to our patients with sepsis, but that really needs to be balanced against trying to avoid overuse or overtreatment of patients who turn out to have non-infectious or at least non-bacterial infection illnesses. And so in this framework, we recommend considering or sort of making decisions about treatment and timing of treatment based on severity of illness and also likelihood of bacterial infection. So for our sickest patients with shock, lactic acidosis, altered mentation, respiratory failure, and mechanical ventilation, we should really strive to treat patients with antibiotics within an hour unless there's definitive evidence of an alternative non-bacterial infection diagnosis. And then for other patients, we should, again, balance both the severity of illness and the likelihood of infection when deciding whether to treat and how quickly we need to make that decision. So I think that this data is really important in terms of informing this sort of pre-test probability about how likely is my patient to have a bacterial infection. So again, across this 1,700 person registry and additional several thousand patients in this meta-analysis, we find that the rate of bacterial co-infection upon presentation to the hospital for COVID-19 is only about 3 to 4%. And therefore, we should really have some compelling evidence of bacterial co-infection and or reserve antibiotics for the very sickest of our patients who are being hospitalized for COVID-19 disease. So in summary, we find that community onset bacterial co-infection is quite rare among COVID-19 hospitalizations, occurring in about less than 1 in 20 patients hospitalized with COVID-19. There's no known benefit to antibacterials in these patients who are being hospitalized for viral illness or viral sepsis, and therefore we should limit our antibacterials to the sicker patients and those with clear suggestion of bacterial co-infection based on their clinical presentation, their lab work, and their imaging findings. So I will close there. I'd like to thank several people. First off, the My COVID-19 Registry, all the hospitals and patients that participated and made that possible, to Blue Cross Blue Shield of Michigan for funding this work, to Valerie Vaughn, who is a hospitalist colleague of mine at University of Michigan who led this analysis, and the many different investigators who all collaborated on this work. And then finally, I'd like to thank ISICEM for the opportunity to present today. Thank you.